Welcome to the National African American Child and Family Research Center's Research Capacity Building monthly webinars. My name is Latrice Rollins. I'm honored to serve as the Director and Principal Investigator of the Center. This webinar is developing a community engaged research agenda. The mission of the National African American Child and Family Research Center is to provide leadership, particularly around community engaged research to better serve African Americans, and looking at our programs, TANF, Early Head Start, and Child Care Assistance. And so we have been working really hard to develop this research agenda by doing what is called a community assets and needs assessment, looking to understand what are the priorities of the population served by these programs, particularly African American population served by these programs, so that we can collect the data and do the type of research that would be most informative for them, as well as for these policymakers and program developers who are implementing these programs. So I have learned from the best, who you are going to hear from today. I've worked with LaShawn Hoffman and Dr. Tabia Akintobi for about 10 years now. And everything that we're doing with the National Center, I have learned from these two. So I'm very honored to have them here to share with you all. And I'm going to stop sharing my screen so that we can get started and get into the conversation. So I'm going to turn it over to you all.
I would like to take this opportunity for thanking Dr. Latrice Rollins for inviting me and my partner in good to kind of share a little bit about our work and work that we do collectively. Our presentation today is doing community-based participatory research, applying principles to practice. And as Dr. Rollins shared, I have the privilege of serving as chair of the Community Coalition Board for the Prevention Research Center at Morehouse School of Medicine. And in my non-chairman role, I really work at the intersection of community development and public health, where for me, it's about how do we improve the outcomes of people and place at the same time. Let me share a little bit about the Prevention Research Center with you. The Prevention Research Center at Morehouse School of Medicine, our theme is risk reduction, early detection in African American and other minority communities. We are a coalition for prevention research, and our goal is really to think about how to implement community-engaged, evidence-based strategies in response to the emerging health disparities and inequities by advancing applied public health prevention and health equity in the state of Georgia, and I'd like to say the state of Georgia and beyond. And we do this through this infrastructure that we've been able to establish, and that was established way before me, but it's really about having community at the center, at the lead. And so as chairman of the Community Coalition Board, my role is that I'm head of our organization chart. It's my job to ensure that the work that we do collectively helps to advance this equitable partnership and achieve our health equity and justice. A quick little plug. We've done a couple of chapters in the principles of community engagement, but if you've not picked up the Morehouse model and how this wonderful school revolutionized community health, community engagement and health equity, I encourage you to get a copy of that. That's a great example of how we've been able to not only move to action and do this in partnership, but to describe what that partnership looks like. The other elements of our current infrastructure really talks about how the center, the core research, we have an external advisory board of national partners, and then how it translates throughout the rest of the Prevention Research Center through the community partnerships, evaluation, training, and extramural research partnerships and protocols. Our Community Coalition Board is composed of community residents, academic institutions, and agencies, with the community having the majority seats, and that serves in the leadership roles, so that we're never outvoted, we're never outweighted, right? It's really important because if we're saying that this is going to be community driven, I think sometimes we think that because we have one or two community members on our community advisory boards or our different coalition boards, that, you know, that represents community. But we've been really intentional about making sure that residents are always in the majority. and that we are not an advisory board. We are a policymaking board that identifies health priorities and improves projects. We help to set policies and oversee the research infrastructure and operations of the Prevention Research Center. We provide information on research activities to other organizations and agencies within our communities and our networks. We help to ensure that there is a clear benefit of community engaged research, and then establishes or sustains trust both with the community and with the Prevention Research Center. And these are a couple of our partners that serve, that is serving or have served on our Community Coalition Board. I think, what we've been able to do and what has kept us kind of grounded in this work is that we've taken each of the community-based participatory research principles and created a community value that coincides with that principle. So, for instance, the principle is to integrate knowledge and actions for mutual benefit for all. And how that relates to the work that we do is that we're ensuring that the research process and outcomes benefit the community, that the community partner is equal at every level, that policies and programs are based on mutual respect and justice. If I take another one of these principles, if I use the one that says involves long-term commitment by all parties, we are really clear that our community value is that it needs to go beyond the grant cycle, that this is a long-term relationship. This is a relationship that if money goes away, there's still work to do, and we are committed to doing that work. Lastly, I think one of the principles says recognize community as a unit to a unit identity. And for us, it's about how do we have a right for self-determination? The community should always have that right. No is a complete answer. And sometimes you have to be able to tell people no. Community has to tell the researcher no. Sometimes the researcher has to tell the community no. But the community having this right to self-determination is an important community value that we've been able to build from the principles of CBPR. And, there are 9 that are here. We've created a community value to each of them. And so, again, here is kind of how we do our work, right? The infrastructure. What does the governance look like? Our Community Coalition Board meets bi-monthly. As chair and the vice chair of our Community Coalition Board, we meet monthly with the leadership team of the Prevention Research Center. There's an executive committee that consists of both the chair, the vice chair, and secretary. All of those individuals are community residents. And then with the academic representative, that's a board member. So Dr. Akintobi is not only the principal investigator, but she's an active board member on the Community Coalition Board as well. But then we have some standing committees that are to the board that are co-led by a member of the leadership team at the Prevention Research Center and a member of the Community Coalition Board. And those are our data monitoring and evaluation committees and our contact, our communications and technology committee. And then as we continue to think about the evolution of our work and how we are continuing to ensure that community engaged research is at the forefront, most of the times projects come before community coalition boards or CABs to get the initial buy-in, and then it's funded, and then the principal investigator kind of goes on. What we said, well, wait a minute, after the funding has occurred and the project is moving forward, we should probably think about how do we continue to have this kind of engaged research committee. And so we have established what we call a CERC, Community Engaged Research Committee, that really allows members of the Community Coalition Board and other experts to serve as a partner to the principal investigator of a research project to ensure that the project continues to move towards success. So it's just, think about that as a community internal review board in a sense, right? It's another way to ensure that community and other experts are helping to move the projects forward. And then we conduct an annual Community Coalition Board Satisfaction Survey. I consider that to be my report card. I consider it to be, it's an anonymous survey that's conducted by each that's conducted and asked of each member of the Community Coalition Board to complete. It's another way for us to be able to gauge kind of how we're in, how board members feel. What does this look like? Where are areas for improvement? What are we doing well? What are the other what are the other um, what are the other things that board members want to be able to see? And so, for us, this facilitates collaborative, equitable involvement in all partners in all phases of the research. And that's basically what we're trying to be able to share with you. It shouldn't just be at one aspect of the work. It should continue to be throughout the entire project.
Thank you so much, Dr. Rollins and LaShawn, for the opportunity to share what we are doing with a broader audience. And as LaShawn just described, not only is that an intro, but hopefully what you've heard are some action steps you can actually potentially take when you think about how community engaged equity in partnership, how does it really show up? And so it's not just about having community representation as a part of your team's planning, but it is making sure that even in the system and the infrastructure and how frequently you meet and the opportunities that people have to bring their talents and interests, that there's a depth of engagement that is not just about the lead of the research project or one community leader, but as LaShawn alluded to, there are 25 seats on this board. So all those different touch points and opportunity for them to engage means that myself as the lead of the research on the academic side, or LaShawn as the lead of the board, it certainly isn't all of us doing that. We have lots of leaders on this board that have different opportunities to plug in and apply their gifts and talents and interests. And this, to me, to us, is the foundation upon which we do community engaged research together. And so what you see throughout our presentation is the way that those community-based public health, community-based participatory research principles have been actually applied. And so if you think about potentially looking at that CBPR principle list, you and your partners or your prospective partners can use that maybe as a foundation and develop your own values. And then we advise you to think about how they show up. So here is one way that one of those principles shows up. So CBPR is cyclical and iterative. And LaShawn already described a bit of that, but it is an ongoing, thoughtful, and intentional process. Whether you're doing a research project or you get some other funding to do a public health or a community-driven program, you already have a lot that you have to do for your funder. But separate and apart from that, what creates that depth of partnership, again, whether there is funding or not, is really being strategic and really thoughtful. And what are those things that are recurring expectations of your partners and the community of you? And so for us, a part of our cyclical and iterative process is conducting a community health needs and assets assessment. So they're typically called CHNAs, but we've actually added another A that represents not just assessment, needs assessment, but also assets, right? And the truth is that our perspective is that communities don't only have needs, but they have assets that usually are underreported, but are the foundation upon which any project will be successful. So the CHNA, or Community Health Needs and Assets Assessment, together we iteratively review the data. We talk about and get input on an idea, whether it's a research project or another opportunity that is aligned with what community has said. And then we think about a health or research project that is responsive to that. We really don't put that yellow box as box number one. It is the community health needs and assets assessment. And we do it in terms of it being an ongoing process. We do a pretty far-reaching CHNA every 3 or 4 years. Some of our projects have built-in assessments that are required of the funder, but separate and apart from funding, we do this across different priority counties in the state of Georgia, priority communities. So that's a part of that cyclical and iterative process where the community priorities are driving our decisions about applying for a project that might be responsive to that. Next slide, please. And so the CHNA, or the Community Health Needs and Assets Assessment, is something that ultimately has the goal of using the results and recommendations to plan, implement, evaluate, and disseminate. And I'm saying all of those terms very thoughtfully. Planning, we know we have to do. Implementation, we know we have to do. Evaluate, we know we have to do. But frequently where a lot of projects in our communities, and by us, meaning those that are marginalized and minoritized, or those that are led by those of us who represent minoritized and marginalized community, we do not emphasize enough the importance of dissemination, telling our story. And Dr. Rollins and the center are doing an amazing job of telling that story, both to the broader national community, but also the scholarly community. And I would say both of those streams are very important. So these are the phases you can see here. And while the number of steps are important, but more important is the process, and that is establishing that this assessment infrastructure is a part of what we do, and it is irrespective of whether there is a grant or not. We must go through this exercise of broad-reaching assessment of assets and strengths, and we use this and actually have evolved to have communities be able to access the data for their own purposes. Students can access the data for their own purposes to address or validate priorities that they've seen. And so we gather the data with, and by the community. And that is not just our board, but also community-based organizations and community residents have supported us doing that. And we've evolved to doing it not just face-to-face, but thanks to COVID, we have a number of virtual networks that we've also leveraged to make sure that we are getting a far-reaching scope of community wisdom. There was also secondary data from local public health sources. We analyze it with the community, and as LaShawn described, we even have a data monitoring and evaluation committee, a smaller group of members who are particularly interested in that data, that not only review the results, but they also adapt and update the survey. As some of you who may be youngish, not young, but youngish, know that there was a time when there was no social media. And the first time that we did the Community Health Needs and Assets Assessment long ago, we didn't have questions on types of social media. Now there are. So as times change, the tool has to change, the survey has to change. And every time we do this, a part of that iterative process is the board and community leaders making sure it makes sense. The questions have that face validity, meaning it means what we intend. And then at the end of the day, we have developed a research and center agenda that is based on what we have heard, and we disseminate that work to the community in many different ways. And so you can see here at the bottom of this slide, 2 of the CBPR principles, again, a cyclical and iterative process. And we could not do this without the strengths and resources of the community to make sure that it had the questions that would make sense. And we're not talking about literacy or even health literacy, but even just the words that are used, that they represent what people would understand and resonate with. And then the resources of the community to say, yes, we will support marketing it, e-blasting it. You can come to our event and get people to consider sharing their community wisdom with you. It took all of us, and those are the strengths and resources in that process. Next slide, please. And so here are just a few of the outcomes most recently. And every time we do this, there are outcomes that we attribute to this process. So when we last did this assessment, which was between 22 and 23, the top 5 community health concerns that emerged included diabetes, COVID-19, mental health, health, high blood pressure, heart disease. We are in the state of Georgia, so some of these may not be unfamiliar. And where you live, work, play, serve, and lead, some of these priorities may be so for you as well. Also, we added a few iterations ago, not just the things that people saw as community health priorities, but also the related health policy systems and environmental issues that really need to be addressed. And so when we think about social determinants of health, political determinants of health, and there are many, many, many others that represent those reasons why, or those things that make having the opportunity for the best health and healthcare easier or harder. And that's all that determinants of health are. They're those things that can make living one's best life easier or harder to achieve. And so you see in that second box, access to healthy foods, access to healthcare. Those are those platforms upon which the health issues exist. And so some of the things that have been the result of that integrated knowledge and action are that we've actually evolved since 2018 and confirmed by this most recent Community Health Needs and Assets Assessment that diabetes self-management, and this was actually before the COVID-19 pandemic, it was something that we saw a few years ago, and we'd worked with the board and local communities since then to evolve ideas about what would an effective program look like? What would make you come? What would need to be the components of that project, and who should be, or which organizations should be among the sites that you think the community would respond to if there was in fact a program. We took that over time as we were doing other projects in HIV and in diabetes and other spaces. And we just over time worked with community leaders to advance that. And our Prevention Research Center, which will be funded again in the fall for the next 5 years, took all of that iterative community wisdom while we were doing many other things. We were listening, refining, and we actually were able to challenge the evidence-based literature through which most diabetes programs have been focused on individual adults to say we want to advance an adaptation which actually focuses on a family-based intervention, because we know that particularly among Black and Brown communities, the social bubble matters. And so we were able to make a strong case, and we will have a funding that really speaks to that. And for us, more important than just getting the funding was that community sites will be trained on how to deliver the intervention themselves and will be funded to be the leads in implementing that intervention. We're also super excited that after having funding through the CDC and the REACH program, which some of you may be familiar with, we have advanced our model as one example with Dr. Latrice Rollins and LaShawn Hoffman being co-MPIs or multiple principal investigators on a new research project that addresses nutrition, physical activity, family healthy weight. And as you can see, some of what we learned from the CHNA really, or the Community Health Needs and Assets Assessment, informed this other opportunity to be responsive. But it also helped to demonstrate equitable leadership in a project through a community principal investigator. And if we have time, we can share other examples of that as well, but we're very proud of that. The other piece of this is that we've really been thoughtful when possible, and we've done it now for almost 10 years, is that we knew that mental health came up actually over the last 8 years now, that mental health came up as an important priority. As you can see here, it's number 3, both in terms of what community residents were seeing as community health priorities, but also a policy, systems, and environmental issue. And so speaking to this whole notion of access to mental health treatment, the degree to which the stressors that people were seeing, both for themselves, but more importantly, that they were seeing in their community required action. And so while it was not a part of the research project, we made sure that we built funding support to offer mental health first aid training, which is a nationally recognized certification for non-clinicians, just everyday people who want to be aware and to get the training to be able to identify, refer, and support people in their social bubble or in their community that may need help, because we know there's no health without mental and behavioral health. And so I want to just use that as a way to emphasize for you that not everything that gets funded has to be a research project, and you don't have to consider a research or a program funding in one and solely one vein. People, we are all dealing with multiple health issues, and we are complex individuals living as individuals in communities that have challenges. And so we need to figure out ways to be responsive and react to what the community says that they need. And so this opportunity to build and train and build capacity, have people to be able to get a certification, and also to support positive socialization of mental health is something that we sought to do together. And it's another member of our board who already had that leadership that was able to facilitate us having that opportunity for communities, residents across the state of Georgia to get that. So the Area Health Education Center leads that and gets funded as a community partner to be able to deliver that in collaboration with us. Next slide, please. So I'm just putting this out there as a reminder. One of the CBPR principles, and I would suggest that even if you're not doing research, if you're doing anything that's community engaged, I challenge you and want to remind others that you have a story to tell. And so we've been very, very thoughtful on prioritizing, disseminating the findings. And so this paper was not the outcome of a particular project or a research study. It was about our process and the outcomes of doing this type of assessment. Whenever we are doing something that could be of benefit to another group of collaborators, community campus, community public health, we want to be able to give people tools they can use and to learn from our challenges in trying to do it well. All of those things, you all, constitute a story. And so this is an example of one of the ways that we disseminated through the Progress in Community Health Partnerships Journal what we did together. And so you can pull this up when the center sends you the slides, and you can see the details of how we did it. I am particularly thrilled, not just that we published it, but that this is a group of researchers, public health practitioners, community residents, all who work together. So again, you have a story to tell, and I challenge you to do it together. And we can certainly share with you. We can put our information in the chat. We're leading a national initiative to really democratize the process of how to write and tell the story of community, campus, public health, and research work together. It can be done, and we're happy to support that movement. Next slide, please. So I want to give you just one other example for now on how a community engaged, a community driven, CBPR driven project at the local level actually advanced to something that was uptaken in a number of sites across the country. And so the EPICS project was a project that was designed to increase colorectal cancer screening. And it actually began several years ago through the Prevention Research Center and the Community Coalition Board in response to increased colorectal cancer rates among minority men and women here in Metro Atlanta, those 60 and older. And so we saw that the rates were higher. And so the board at the time, which preceded any of us, they thought that it was important to do something about it. So there was a Metro Atlanta Coalition on Cancer Awareness, community leaders, and the Community Coalition Board of the Prevention Research Center got together and said, hey, we need to do something about it. And so it started with looking at three models, three arms of an intervention to see what would be most effective in increasing the colorectal cancer screening rates for African American older adults. And so the three arms of the intervention that were tested was a traditional arm, where the doctor sees the patient at the health visit and educates them and recommends cancer screening. The other arm was an arm that assumed that, particularly for Metro Atlanta communities that were of lower socioeconomic status, which was where we saw the lower colorectal cancer screening rates, that a financial incentive to make the cancer screening free would be the motivator. That was the other arm. So not working with the doctor, but maybe getting education elsewhere and getting a voucher to get the screening. The third arm was looking at a peer-to-peer approach where elders in the community were trained on how to talk about, educate, and support their peers in considering going to get cancer screening, colorectal cancer screening. What we found in that model was, of the three arms of that study, one that was driven by a physician, one that was driven by money, and one that was driven by a CBPR approach by peers who were trained. We found that those who were trained by their peers were statistically significantly more likely to get colorectal cancer screening. That data demonstrated that a CBPR approach with peers as the champions was most effective. And then we had you use that data to spread the word about it. And that particular model of peer-to-peer training was uptaken in 17 senior centers here in Metro Atlanta. So we built a case on the importance of a CBPR model that was proven to be effective. And then it was uptaken in 17 senior centers in Metro Atlanta. And that data was then used to be able to make the case with the National Cancer Institute to implement that science, speaking of implementation science, in 20 sites around the country that are now implementing the EPICS program. I say all of that to say that local, small scale programs that are not necessarily developed solely by experts, but using a CBPR approach with peers, can build the evidence for projects that ultimately advance the art and science of what might be adapted in different ways across the country. So we went from a CBPR approach locally to one that has been uptaken into an implementation science adaptations across the country. And now they are implemented because there's an evidence base that started small. And so this story demonstrates that research processes and outcomes can benefit the community at different stages. Just one story of what we've done. And I know that many of you are adapting things at a small scale and locally, but I want to remind you that it is important, the community engagement and also an evidence base, as well as spreading the word, can result in large national, regional, and national dividends that benefit the community. Next slide, please. And we published it. This was iterative and cyclical. This began many years ago, very small. And now, many publications, many iterations, many cities later, we just published last year this time in the American Journal of Preventive Medicine, what we learned about the process of starting small and advancing to something that has gone national. Your story matters. Next slide, please. And then I'll speak very, very briefly about Reach High. And so Morehouse School of Medicine has had a REACH grant in the past. Some of you may be familiar. It's funded through the CDC, Racial and Ethnic Approaches to Community Health. And we spoke earlier about the importance of projects that are not strictly research, but are complex, like communities and health issues are. And so we received funding from 2014 to 2018 to reduce diabetes, disparities in diabetes and cardiovascular disease. This was a project that was also responsive to the community health needs and assets assessment, and had many prongs, and was a super complex project with the realities of how complex communities were. At the time, the focus was on policy, systems, and environmental change. Next slide, please. And so what we did through this project is to make the business case through talking with community residents on how offering access to community responsive prices, as well as opportunities to be able to get healthy foods in corner stores, a reality. And so while there were many complexities of this project, what it helped us to understand was the power of community engagement, but also the power of local businesses as being champions and advancing access to opportunities to create safer spaces for physical activity and to promote healthy access to healthy food. So what we did learn from this is that the work is complicated, but the relationships and the opportunity is an opportunity to learn lessons, but also to engage the business community in thinking about health as something that's also their responsibility, and that how we can be a collaborator with them. So there were a number of corner stores that were engaged and worked with us on this initiative. Next slide, please. And we published it. Again, even when projects evolve with their complexities, it is essential that we tell the story of what we did. And again, we have a few opportunities coming up that we'll share through the center on how you can get the skills and flex the muscles of telling your story. Next slide, please. And I think, LaShawn, you'll say a little bit about Encourage ATL. I think I teed you up well earlier.
You did.
New project, yes.
So I will tell you that, sometimes we want to move to action very quickly. And when we first start to think about how do we start to address some of the concerns that community had around diabetes, we started writing and thinking about what do we need to have an intervention that could incorporate both kind of parents and children, kind of adapt some of the best models that were out there to make it relevant and culturally relevant to the communities in which we were serving. And we came up with this approach, the CBPR approach to diabetes prevention called Encourage ATL. Let me first start by saying we worked on this proposal maybe 3.5 years. And so where one funding entity might tell you no, I would want to just encourage you to keep pushing forward. What happened for us, because we firmly believed that this was the best method that we believe that would address the concerns in the communities in which we live, work, play, serve, that we wanted to continue to think about where was the best funding entity that can help us to move this project to fruition. And so through Encourage ATL, the planning process, as I shared, started in 2018 from our community health needs and asset assessment, that it was guided by a community project review committee that partnered with researchers around how do we use this CBPR approach to leverage our community academic collaborations, kind of, what is this long-standing community stakeholder partnership, as well as how do we reduce type 2 diabetes and cardiovascular disease among Black families through the adaptation of some family-oriented Encourage intervention. We started in 2018. We got it funded through 3 different sources in 2023. But again, if you remember when we started to talk about the principles of community-based participatory research, right, and the community values that we've created to go with them, this involves a long-term commitment by all partners. if you're only coming together because the grant requires you to come together for this one funding entity, I'm not quite sure if you've really built trust and you're building relationship. And so again, it is through this process, although it took us this a couple of years to be able to kind of really move it forward. The end result is that through 3 different funding sources, we're able to implement aspects of this great work that we were doing and that we were planning for in 2018. And in one of those structures that this has been able to be implemented is through a joint partnership, right? One of the, I think the power of the work that we do at the Prevention Research Center and our Community Coalition Board is that our board has been adopted and has had several adaptations, and one of them is helping to support the Georgia CTSA community leaders, right? And so through the Project Peach, promoting engagement for COVID-19 testing and health, it was through the RADx Up project that really looked at diabetes and COVID-19 and kind of the associated morbidity and disparities. And so in our true form and fashion, we have the researchers on the right-hand side and the community investigators on the left-hand side that brings all of our level and expertise together to move the project forward. Again, I think what we're at least trying to share with you today is that community members, and through kind of this opportunity to learn and close the learning gap, I became a community investigator. I really became more invested. Dr. Akintobi shared with you that I serve as a co-principal investigator with Dr. Rollins on our REACH grant. This isn't something that I originally started to do, right? I shared with you in the beginning of the presentation, my work was really in community development. But thinking about those policy systems and environmental change, environmental issues in which community identified member housing, that was my work. We know that when you take those kind of issues and then think about those health disparities, this work really matches and really pairs well together. And so this is one of the ways that we've been able to kind of move the community need forward around how we're addressing diabetes. And so, you know, Dr. Akintobi and I will share with you that, context matters.
Mm-hmm. Absolutely.
Yeah.
We want to encourage you to measure what matters. And so it really, as you think about partnership, you want to think about, yes, what your funders or your organization requires, but one thing that I have been clear on for a while is that any relationship lasts because each partner has taken the time to understand what the other partner values, appreciates, what makes them tick, what makes them respond, and are feeding that. And so you can apply this to your personal life, your professional life. It certainly applies to community engaged research and practice. And so it is essential that we consider when we talk about social determinants of health, they're also determinants of effective partnership. And we must work together to continue to advance the art and science of how we actually measure that. And we've spoken a bit earlier about things like the CCB satisfaction survey that is really thoughtful and actually has evolved in terms of specific domains of the partnership that have been valued and measured. We've also talked about the community health needs and assets assessment that has been used to figure out what communities are caring about. And for those of you who may be interested, it also talks about what they are seeing as health issues that they're dealing with. And as you might suspect, the things they're seeing or what they are dealing with may also be different. So context matters. Partnership processes matter. We also assess how people feel about the frequency of meetings, the degree to which they actually are involved in having a forum to collaborate together, or the degree to which they feel that they are connected with local policymakers as a result of the board, or with the leadership of the school, which is something that the Morehouse School of Medicine is one example. Do they feel that they have access and have opportunity there? And then, of course, we want to be sure that the project or the intervention or the research that we have outcomes there. And I also emphasize the importance of diversity, equity, and intersectionality in addition to inclusion. We know that there certainly is an evolving reality in how DEI is showing up, but more so than the term, I think is the action related to how we ensure that those who are not there or that should be at the table are there, not in token, but in majority number. So wherever an inequity exists, we must work triply hard to ensure that that representation is not token, but in the majority that history or current day has made our responsibility to flip in terms of the script. Next slide, please. And LaShawn, I don't know, of course, people can see this on their screen. I don't know if there's any on this list as we put some ideas for folks to think about in terms of measuring what matters. If there's anything on this list that particularly stands out to you as something we've advanced or that you think is important to advance as people think about community engaged research.
I think there's a couple, there's two that I will immediately talk about. One is around the shared power relations and research and knowledge democracy. I think so many times community shows up and we come to the table because there is an interest in the work that's happening there. But I've noticed and some of the work that researchers don't want to share the power. And we've learned that by sharing that power, both in the research and the knowledge democracy, we've had our projects to not only be enriched, but to be deepened and to be sustained within community. And I know that sometimes it's a hard thing to talk about what does shared power looks like, right? And still maintaining the integrity and the rigor of the project that you're working on. The other is around the growth in the individual partner or agency capacities. I just remember when I joined this board in 2006, I came with absolutely no background as it relates in public health, and to think about what will it take to be a researcher. I was really apprehensive in this work, saying that this wasn't my field, but then by showing up and then learning, and then for not only kind of the center investing in me, but also valuing the knowledge that I brought to the Community Coalition Board, my own individual growth has happened where I can serve as an expert in community-based participatory research. I can actively serve as a principal investigator and bring my full self to this work, right? And also connect those dots. And so I really think of myself as a bridge builder, because that's what sometimes that's what it takes in order to ensure that these community campus partnerships are successful and that are moving forward and that are not just in relationship just because there are dollars on the table.
So we know we have more work to do, and certainly as you think about those outcomes and priorities in terms of measuring what matters, we also want to advance and change policies and conditions. We know that academic institutions are not necessarily ready to equitably and quickly work with community partners and getting their contracts and agreements routed quickly enough. That is where the clear inequity shows up. And so how do we advance? And LaShawn, myself and Dr. Rollins and others have been a part of some work with other institutions on really understanding the institutional determinants of effective community engaged research. And that it's not just about the people in partnership who are mission aligned, but there are organizational challenges as well that we must acknowledge and work towards addressing. And certainly we want to improve health and health equity. That is our collective journey. Certainly we want to look at the conditions, the systems, those determinants of health, but we also then want to look at changing those disparity trends in burden of hospitalization, illness, and death. When we think about the objectives here, how do we change those outcomes and all of the risks and facilitators and barriers that go along with that? Next slide. And I know we need to get to questions.
Right.
And so,
and
yeah,
we're bringing this to a close, but just think about, so here's some of what we believe are some of the benefits to the community partner research from a community perspective, right? That, offers of support for community projects which are not related to the core project, but overall health related. We know that many of us in communities and our agencies or our community partners are doing other things. It's important for us to feel like this is a two-way street, that this isn't just about what the Prevention Research Center's intervention is, but how do we support each other, right? How do we work with our community-based organizations on establishing evaluation processes of their community initiatives? That alone, that technical assistance in establishing an evaluation process could help to lead to additional funding and supporting your partners, your community partners, and ensuring that they can be at the table when you need them, right? So many times I think that I've experienced in running a community-based organization, people want me to show up and don't value my time. I should be compensated as well. There's a lot that we put into this, right? And so establishing those evaluation processes was a tool that helped me to forward the work that I was doing in the community. Partnering towards these joint internship opportunities, it was so valuable to have students and that were needing some expertise to come to my organization and to not only assist me in moving some of my work forward, but to give them that kind of hands-on experience. We have to create those opportunities because over this weekend, I'll tell you that we were talking about age, and I kept telling people that I was a medium age. I wasn't quite young and I'm not old, I'm medium. But we know that, part of our job is to really educate the up and coming workforce, the up and coming practitioners. And so providing those internship opportunities that could be paid or not paid are important. And then hiring community health workers, residents that live within the neighborhoods. It brings, I think, an additional level of trust and commitment to the work that you're doing. And so these are just a few of what we believe are some of the benefits of a community partner research agenda from the community's perspective.
And then on the academics perspective, and this is absolutely not exhaustive. So as you think about your own organizations and agencies, you might plug that. It may not be academic, but it might be an agency working with community. And we know that sometimes there's a difference between an agency and the individuals in it actually living in the community. So we understand that distinction there, but it promotes our community credibility. While I am on the path to continue trustworthiness, I know and I'm very clear of my position in an academic institution. And so this requires me to not necessarily be able to do and know everything, but have people that have that established credibility and trust and get on their agenda. Increases recruitment and sustained participation. That is not the only purpose. And as we've talked about during this whole discussion, it is about partnership and collaboration. But when those foundational pillars have been there, it makes it easier for the community or patient groups to say yes, because they know that these partners are trustworthy. They are there when there is no money. They are there in meetings, not to push an agenda, but just to learn, listen, and understand. It expands funding and human resources because together we are able to collaborate to bring resources to all partners, and in many instances, resources and grants that are led by the community with our support in providing capacity to them on how to effectively write grants that have Morehouse School of Medicine's name nowhere within the budget. But this history of relationship creates the opportunity to be trusted and to have a track record and to get funding to do the important work. And then the collaboration is important to disseminate and share emerging models, best practices, and outcomes in community engaged and associated research. And I think we're just about done here. We've learned many things. And LaShawn, if there's anything here that you want to take as we close out, I yield to you.
I just want to say that, we've learned from the things we've done really well. We've learned from the things that we have not done really well, right? And being able to tell both of those stories, there's lessons to learn, and it allows us to be not only kind of transparent, but also to be honest with each other, right? And thinking about, how do we ensure that our relationship is strong and strengthened, could be challenged, but again, how do we do this for at the end goal of improving the health outcomes of people and in the places in which they live. And so I think it's been a privilege for us to be able to share. We'd love to take a few questions while we still have some time. But thank you for inviting us and for hearing how we do our work, our collective work at the Prevention Research Center at Morehouse School of Medicine.
Wow, thank you so much, both of you, for sharing. I was upset because I couldn't find the reactions to send the hearts and send the applause throughout the presentation, but I think it is without question why the two of you are presenting across the country about this model of community-based participatory research and the great work that you all do. Even though I think a lot of our audience is focused on maybe a poverty alleviation program or early care and education programs, I think you can take the principles and the processes that were shared today and apply them to whatever research or program development, intervention development that you're doing. And so, particularly now when we have a lot of equity action plans being developed across agencies, and they're calling for people with lived experience to join in with agency staff or researchers. So a lot of folks are developing boards and things that include folks with lived experience. And I was waiting for you all to say, but can you share why our board is not called an advisory board? Because I do see that a lot in the various agencies, like they have a parent advisory board or that, but can you share why we don't use that term?
It's because it's important for us around the shared power, right? It was something that was established before Dr. Akintobe and I, to simply say that if this is going to be something that's ingrained and supported by community, then community should have somewhat control of it, right? If this work is supposed to be grounded and rooted in community to help move the needle towards health equity, then it was established to say that this would not be an advisory board. This would be a policy making and governance board. And this is how we do that. So we have bylaws that allows us to navigate what that relationship looks like, but also kind of set the intentions of this, that we don't expect the board to go away when the project ends. This is helping us to figure out the terms of what our relationship is going to be. And so that's why we're not an advisory board. And that we're not disease specific, right? So you're right, Dr. Rollins. We can take these same principles. I take these same principles and use them in other settings. When I'm talking about community design, I take the same principles and think about when I'm talking about environmental issues. And so we're partnering with some colleagues in Middle Georgia around a zoonotic disease, transmission of zoonotic diseases, right? Which doesn't really seem like it could be public health, but really thinking about how they strengthen their community campus partnerships, because these principles, when applied and when followed, can really help, I firmly believe, enrich a project, but also can be applied in any setting, right? It really helps with moving community forward. Dr. Akintobe, I'm not sure if there's something you want to add.
The only thing I'd add is that, language matters, and advisory advice connotes, I can take your advice or I can leave it. And so back many years ago, community leaders said, if this is going to be not that, then coalition is better, because it really connotes shared governance and policy making as the tenets of the relationship. To flip that script from the communities being kind of the passenger advisor versus being in the driver's seat and ensuring that both the historical as well as the current justified hesitancy that communities have in engaging with the academy or with agencies, that we were intentional about flipping that script. And so the bylaws and governing principles are ways that for those who want to do it, you can better understand all that is in there that helps you to see how it's applied and practiced.
In an urban context, Dr. Rollins, it's FUBU, for us, by us.
For sure, for sure. And I think that it kind of is one of the challenges, particularly the governing side of it, because in some of these agencies and even in our institution, academic institution, it's like there's some things that just are harder to change or that just won't go. And so when a community coalition board or folks with lived experience are providing a recommendation that possibly will not be implemented by the organization or the agency, maybe talk about some of that as a challenge. Like these are things that we, have been recommended and that need to change, but because of the institution or the agency, they're kind of, hands are tied in terms of what they can move forward with.
I'll give you an example. When we think about working with returning citizens, right? And we then think about, well, oh my goodness, this is a great population for us to think about how do we either help them improve health, or we're thinking that there could be substance abuse there, and we want to have peer educators. Well, I've really questioned the model of saying, is the academic partner the best agency to lead? Because is it that we want peer educators, but we can't hire the peer educators because our institutions don't allow us to be able to hire people who have a felony, but believe that the work is important enough for us to do research around? So maybe having a community lead to take over that is a second chance provider, so that person, that peer educator, can get health benefits. I mean, come on, let's really be honest about this thing, right?
Yeah.
Or is it that we just want to be able to have our intervention or our thoughts kind of investigated and thinking about what are those conclusions, and we don't leave people better off? It's more than just the intervention. It's about how do we improve the life of the people. And
Right.
so it's a challenge in which we've had to address. We've had to adapt. We've had to have honest conversation to say, this ain't working.
Yeah.
And how do we make it work? So that's one example, Dr. Akintobi.
And that was not a case out of the sky. That was real. We had to talk with our HR department here at Morehouse and say, look, this is what we're trying to do. This is what you are proud that we have gotten funding to do. This is when our core research project was called PIMTAG, prison intervention,
meeting them at the gate.
As they were being released into the community. They had gotten education and now were re-entering communities. And we had phenomenal folks that were on that we knew would be great for the position, but they were applying and couldn't get through for the reasons LaShawn described. So we need to really speak with honesty about those challenges that exist. And maybe those, many of us, and if you hadn't, this is what's called an upstream factor. Those things that are going against the easy way, but represent those equity issues that are critical when we're thinking about the process of doing community engaged research authentically. This is not the road most frequently challenged, just to let you know.
That's right. Well, thank you both. I don't see any questions. The one question that was there was about opportunities for students to get involved in the work, in which I answered and said, yeah. I mean, thankfully, COVID has this, opportunity for us to do Zoom and do a lot of things remotely. And so, yes, there are always opportunities for students and anyone really to be engaged in the work that we're doing, capacity building opportunities, a lot of different things. So please connect with us, and we'll make sure that we find out what you're interested in and see where we can use your talents and gifts. But this has been great. Thank you all again so much. So honored that you're able to come on and share with us. And at that, if there's not any concluding remarks or anything like that, we'll sign off.
Thank you.
Thank you all again. Have a great rest of your day. Bye-bye.